Necrotizing fasciitis. What is the definition of necrotizing fasciitis? It is severe, rapidly progressing infection of the soft tissues and fascia, and with significant morbidity and mortality. What is the mortality rate of necrotizing fasciitis? It is around 30 to 50%. It is characterized by extensive necrosis and toxemia. It has a feature like in this usually the muscles are spared. They are not involved in necrotizing fasciitis. Next, types of necrotizing fasciitis. There are 4 types of necrotizing fasciitis. Type 1, 2, 3 and 4. In type 1 it is polymicrobial, type 2 is monomicrobial, type 3 is gram-negative rods, type 4 due to fungal infection. Polymicrobial here as the name indicates, it is due to multiple organisms. So it is a synergistic action of non-group A streptococcus along with anaerobes or clostridium or enterococci like E. coli or Pseudomonas. Whereas monomicrobial, it is due to a single organism, single group of organism like group A beta hemolytic streptococci or methicillin resistant Staph aureus. Whereas type 3 it is due to gram-negative rods like Vibrio vulficus. Type 4 is due to fungal infection like Aspergillus zygomycetes. Most locations that are involved are in type 1, it involves perineum, trunk, and postoperative wounds. Whereas type 2, it mainly involves extremities. Type 1 is seen in diabetics and immunosuppressed individuals. Whereas type 2, it is seen in young patients without any comorbidities. Okay, why I'm stressing these two are because type 1 is the most common type, whereas type 2 is second most common type of necrotizing fasciitis. Few points about type 3. Type 3 it is usually seen after a history of trauma, minor trauma in patients with chronic liver disease, chronic renal failure, diabetics, and patients who are on steroids. And this type 3 and type 4, both these types are rare. Next, coming to sites. Most common site is lower extremity. Around 60% of patients present with necrotizing fasciitis involving lower extremity. Other sites are genitalia, groin, lower abdomen. Here there are some special mentions like if it involves perineal region, not perianal, perineal region, it is called as Fournier's gangrene. Okay, it is seen in patients with diabetes, cancer, malnutrition, and any recent urogenital or colorectal instrumentation or trauma. Okay, it actually progresses from the genitalia to perineum and to the abdominal wall very rapidly. So it is a surgical emergency. You have to debride immediately and also put on higher antibiotics. Okay, and another such special type is necrotizing fasciitis involving the abdominal wall, which is called as Melanese gangrene. Okay, even NF also affects vulva in case of females. Okay, how it gets infected, how it gets involved is after an infection of any skin appendages and following biopsy or episiotomies, it actually begins as cellulitis and later it extends through the facial planes to develop the necrotizing fasciitis. Okay, then coming to risk factors of necrotizing fasciitis. Most common predisposing feature of any necrotizing fasciitis is trauma. Around 80% of patients will have a history of trauma, and it is more common in patients who are old age patients, and who are smokers, diabetics, immunosuppressed individuals like on steroid therapy or HIV, and patients who are malnourished, even obese patients, and patients with pressure sores, IV drug abuse, perineal infections like perianal abscess or Bartholin cysts, and skin infections like or trauma like abrasions, boils, and bites. Okay. Among these, the most common comorbidity associated with the necrotizing fasciitis is diabetes mellitus. You have to look for it. Clinical features. There are local manifestations and systemic manifestations. First, local manifestation. Patient comes to us with complaints of severe unusual pain and edema of the leg and discoloration of the skin. So when you observe, there will be erythema of the skin, edema, and there will be local rise of temperature and tenderness. On applying pressure, you can appreciate crepiness, and the texture will be woody hard. Next, there can be bullae or blisters. When you break those bullae or blisters, it releases some dishwater type of pus or drainage. And also there will be fixed staining, discoloration of the skin, later developing the skin necrosis, gangrene, and ulceration. Here you can see discoloration. What happens? Initially, there will be progressive thrombosis of the vessels, which leads to necrosis. It results in skin turning to dusky blue or black. Later, it results in formation of bullae, and it progresses to the formation of gangrene or cutaneous gangrene or necrosis and ulceration. Okay, and also it may appear as a single discoloration, large discoloration contiguously, or it may appear as a skip lesions which may later enlarge and coalesce to form a large area of discoloration. Okay, and these are the local manifestations. Coming to the systemic manifestations, there can be fever, increased heart rate, increased respiratory rate. Patient may land up in shock, coagulopathy. Then each organ system will start to fail, resulting in jaundice. And what happens when there is a septic shock? It results in hypovolemia and cardiovascular collapse. Then the blood flow to the kidneys will decrease, resulting in acute renal failure. Eventually, patient will land up in systemic inflammatory response syndrome, then to multi-organ dysfunction syndrome, MODS. So these are the systemic and local and systemic manifestations. Coming to the stages of the disease. So initially, there are 3 stages. In first stage, there will be fever, erythema, edema, warmth, and tenderness. Here you can see the limb is swollen and there is edema of the limb. There is edema of the limb and erythema. You can appreciate the erythema. And in second stage, there will be appearance of blisters or bullae. Here, these are the blisters or bullae. And in third stage, The skin will be the region will be hypo or anesthetic. Hypoesthesia or anesthesia, and on palpation you can hear some crepitus due to gas forming organisms infection. And tissue necrosis, here this is an area of necrotic or gangrenous tissue, and hemorrhagic bullae. Here you can see the bullae is not clear, here it is clear, here it is not clear, it is hemorrhagic bullae. There is a scoring system for necrotizing fasciitis which mostly don't know, that is LRINEC, that is Laboratory Risk Indicator for Necrotizing Fasciitis. It is used to assess the severity of the disease. So in this there are 6 parameters. One is C-reactive protein, total counts, hemoglobin, sodium levels, creatinine levels, and blood sugars. If the C-reactive protein is more, then we'll add highest score of 4. If the total counts are more, if it is 15,000 to 25,000, score 1, more than 25,000, score 2. If HP is less than 13.5 up to 11, it is 1. If it is less than 11, then 2. If the sodium is less than 135, we'll add the score of 2. If there is more creatinine, we'll add score 2. If there is hyperglycemia, then you add 1 point. So how do you assess? Here, if the score is less than or up to 5 or less, then the risk is low. If the score is 6 or 7, then there is moderate risk for developing necrotizing fasciitis. If the score is 8 or more, then the patient has high risk. But the performance of this scoring system, LRINEC scoring system, is still questionable. There are still studies going on whether it is valid or not. Next, diagnosis. Mostly necrotizing fasciitis is a clinical diagnosis. Based on the clinical local manifestations we have discussed, you can diagnose the patient. And if you want to do some other tests, there is something called as finger test. What is it? If there is a limb, extremity with a discoloration, edema, and the feature suggestive of NF, and let's say this is the area of discoloration, then area of suspicious NF. First, you have to infiltrate the area with local anesthesia. Okay, infiltrate it with local anesthesia. Then you give an incision of 2 centimeters on the skin up to deep fascia. You should even open the up to deep fascia, should give the incision. Then you observe for any bleeding. If there is no bleeding, it is one of the sign of necrotizing fasciitis. And on incising, there will be some discharge. That is like dishwater. If there is dishwater colored fluid coming out of the wound, it is also a sign of necrotizing fasciitis. Then I call the test as finger test. But we haven't done anything. Now you have to put your index finger with sterile glove into the wound and probe it. Probe it at the level of the deep fascia. If the tissue is dissecting with minimal resistance, then the test is positive. Okay, then the test is positive for necrotizing fasciitis. That is finger test. Next, tissue biopsy. You can also send the tissue for histopathological examination, where you can see obliterative vasculitis of subcutaneous vessels and acute inflammatory cells, and subcutaneous necrosis can be identified. Okay, and the creatinine kinase may elevate in case of necrotizing fasciitis. And radiographs. If you take a radio or X-ray of the part that is involved, then you can appreciate some air in the tissues because of infection with gas forming organisms, right? But taking radiographs is not mandatory. You should not delay the treatment by waiting for radiograph reports. Next, coming to the management of a patient with necrotizing fasciitis. First, you should admit the patient in critical care or intensive care unit. Then you should monitor the volume derangements and cardiac status. And you have to start on broad spectrum antibiotics like third generation cephalosporins and metronidazole. Okay, if it is a type 2 necrotizing fasciitis, that is monomicrobial or beta hemolytic streptococcus group, then you should also give clindamycin, because it is a potent suppressor of bacterial toxin synthesis. Okay, and also you should catheterize the patient and monitor the early urine output, and if the patient is diabetic, control blood sugars, and oxygen support is beneficial. If required, you should also intubate the patient if required. Okay, do not forget to send the wound swabs and blood for culture sensitivity, because they help us in changing to the appropriate empirical antibiotics in the later period of treatment. And another, if the first main thing is broad spectrum antibiotics, and the next main thing is immediate surgery. What do? We do radical excision of necrotic tissue. What is it? Here we excise the tissue beyond the area of induration, and the wound should be lightly packed with the gauze and dressed. Okay, and later we should go for a second look operation after 24 to 48 hours based on clinical response. If required, we can go for second look debridement, and it may also require multiple debridements, because the necrosis is prone to spread beyond the wound edges. Okay, and later uh, we should do daily dressings, and wet dressings are beneficial to improve the healing process. And also the hyperbaric oxygen therapy, it is reported to decrease the mortality rate. Therefore, it is also beneficial and important. Okay. Once healthy granulation tissue is appearing and the patient's clinical condition is improving, then we can plan for skin grafting, that is a split thickness skin grafting, to cover the large area of the wound. Okay. So this is about the necrotizing fasciitis. So the take-home message is the NF is rapidly progressing infection, and which may lead to septic shock and eventually to MODS and death. Right? So therefore, a prompt and timely treatment is must to decrease this mortality and even morbidity. What is the timely treatment? Like antibiotics, high-grade antibiotics, debridement, and monitoring. Monitoring is also important. So be quick and clear to diagnose and treat the patient. Thank you.